My name is David Mathews. I'm from a small rural community south of here, Grove Hill. My grandfather said it was the spiritual capital of the state. There were no other contestants, so I guess we are. I went to the University of Alabama. I studied history and classical Greek. I went to Columbia and got a PhD in history. I came back to help a friend, John Blackburn, who was the dean of students, dean of men, I guess, in those days. And he wanted to get his degree, so I agreed to stand in for him. I really wanted to teach history. That was my purpose, but he had been helpful to me, and so I took his place while he went to Florida State for a degree. The university was, as always, having trouble with the legislature, and my grandfather and great-grandfather had both been in the legislature, so I went down and worked with the legislature to try to get the appropriations that we needed. And then the president left. Students were very active in those days, and they selected me, I thought, probably because they thought I could outrun them. I was reasonably fast. So I became president and did that for a decade or so. I took a leave. I went to Washington to serve in what was then the Department of Health, Education, and Welfare, HEW, which had, everything from Social Security to all of health. I came back here after my leave and stayed until I went to the Kettering Foundation, which is a research foundation.
And it was before you left for Washington that CCHS.
Well, I think it's important to put that in context.
Okay.
This is the 70s. After the stand in the schoolhouse door had failed, all of that energy that went into maintaining segregation was now available. And the university could be the university to the whole of the state of Alabama. So it was a decade of incredible change, a little turmoil as always, but I think 31 of the existing academic programs were founded in that decade.
Oh, okay.
A little over 40 in the 15 years after the stand in the schoolhouse door. And most of them were outreach programs. They were relating the university to the state in a more comprehensive and we hope useful way. One of those changes, experiments, innovations was the College of Community Health Sciences. It came at a time when the state was also facing a crisis in healthcare. There were few doctors for some counties had only one or two, some had none. They were older, retiring. We were having to recruit medical professionals from other states for Alabama. And people were concerned about it. That led in the late 60s to some consultants coming in, and they wanted just to increase the number of doctors. Seemed the logical thing to do. You're running short of doctors, train more doctors.
And these consultants were brought in by the state or the?
No, they were brought in by the university. I've forgotten the name of the organization that came in. And So they asked the university to help. The first idea was that we would just do more basic sciences here. Then somebody said, well, maybe some clinical programs for the students at the medical school. Do a couple of years of that. So here we began to look at what was going on, visited, talked to a lot of people.
Throughout the state? Or?
Throughout the state and throughout the country, really. We visited I don't know how many places.
And at that point in time, what was available in terms of medical education?
But what we discovered was that health was certainly a matter of medicine, but it was far more than that. And people were just beginning to sense that, and they were beginning to think about very fundamental reforms and changes in the way health was provided.
Right.
In particular, we were impressed by what the University of Kentucky was doing. Actually, this work had started in Yale with a fellow named Bill Winter. And he had a very controversial idea. We were beginning to have more and more specialties. And he argued that family practice was a specialty.
Right.
And he authored a report saying as much. It was met with some, I wouldn't say, well, I would say opposition. The most radical thing, though, was the opening of a field called community medicine.
Okay.
And community medicine said, or community health, you don't just treat individuals. You have to take the whole community into consideration. And this was early on when we didn't fully appreciate what we know now, which is the high correlation between the character of a community, the characteristics of a community, and the health of the people that are in it.
Right.
Bill Willard was obviously one of the leading people in this field. And we wanted to recruit him. In athletic terms, he was a 5-star. And we found out that he liked to grow catfish. And it so happens that catfish feed when the water is warm. They'll go dormant in the winter. And in Moundville, there is a spring that comes out of the ground warm, stays warm all year long. So we got Victor Poole, who was the banker in Moundville, to find a piece of land with, it didn't have a catfish pond on it. You could build one and use that spring. So we brought Bill down, we flew him down and did the usual tour. But the highlight of the tour was going down to Moundville and looking at this piece of property and letting him put his hand in the spring water and see how warm it was. So we got him. We got really I don't think there was anybody better in the country. He came in and he recruited some people from Harvard and Yale, some from UAB, and then he went out into the state. If he was going to teach family practice, he wanted the best family practitioners available, and he brought those in. And that created the core for the faculty. He was quite happy to provide some clinical experiences for undergraduates for the medical school, but that really wasn't the main focus. The main focus was on residencies, because if you wanted to get medical professionals into rural communities fast, residencies pay off much quicker than 7, 8 years of medical school. And I guess the best example of what you could do is Sandrell Hewlett. Very good physician from here in Alabama, trained though at the University of Pennsylvania, I believe, yes. And came in and, you know, within short time was in her hometown running a clinic. So residencies and clinics, not a hospital everywhere, clinics that would feed into hospitals.
Right.
So the idea was to create a new specialty family practice and to expand from just treating individuals to taking the community into consideration. We didn't know a lot about the resources that are in a community that can affect health. Behavioral medicine was just embryonic. It wasn't even visible enough to be controversial. But you know, we know now that a large percentage of the things that put people into the medical system have to do with behaviors.
Right.
And communities have the greatest effect on behaviors. So if you want to affect behaviors, the place to start is the community. We were also just beginning to be aware that communities had assets that didn't look like the normal assets of money and authority.
Right.
The greatest asset they have for medical purposes is the ability of one human being to care for another human being. And now we've got some great studies. The one I remember most is Rosetta, Pennsylvania. A group of Italian, I think, mine workers come into this community. You know, the work is hard, it's dangerous. There were no special medical facilities there to help them, just the usual. But these people lived incredibly long lives. They were healthy. And the reason was that they had come to a new country, they banded together, they took care of one another. They took care. And so we were beginning to understand the power of a community as itself a health resource.
And was that unique at that time?
That was very unique at that time. So when Willard comes here talking about family medicine, what was it? Somebody called it, somebody reacting to it, called it that bastard profession, okay? And if family practice was controversial, the notion that a community, not just an individual, should be the focus. The notion that it had resources, that was out of space. That was another planet.
So the model for CCHS was then unique.
It was, but here is the distinctive thing about what John Burnham, who was one of the pioneers, he said, we didn't have a plan, we developed a vision. And the vision was that you could take a comprehensive state university and you had all of the other professions that you needed to mount an armada of healthcare. You had psychologists, we had a good psych program, you had lawyers, you had business people, you had social work, you had education. There was a real potential that all of these would come together. Not that we would just have one new college called the College of Community Health Sciences, but the university would launch an armada of professionals and caregivers and support for those caregivers and other professions that would transform health in the state of Alabama. And more than that, we had a foreign policy. We wanted to form a close alliance with the medical school in Birmingham, and we wanted to engage Auburn Pharmacy School and that enormous network of extension agents.
Okay.
So we had a very different vision.
Not your typical school of medicine.
Not your typical school. So you can imagine opposition came from nearly every quarter except the people of Alabama.
Okay.
Particularly the legislators from areas where they had understood it perfectly. We had no trouble in getting financial support from the legislature.
Okay.
Off the bat, $4 million to expand and develop facilities.
Did you have to spend a lot of time in Montgomery trying to secure the funding?
Yeah, we built an alliance, statewide alliance for, I've forgotten what we called it, the Rural Medicine Initiative or something like that.
And was that easy to put together? Was that, did you find
Well,
there was a
in
lot
terms of,
support for that?
it was a lot of work, but it wasn't the hard sell that you usually have with the legislature. People understood it, they were for it. We had two governors at the time, Albert Brewer and George Wallace. They both endorsed it.
Okay.
And in fact, it became so popular that others joined in. Huntsville, Mobile, it was already on track.
Was this part of your desire to have the university engage with communities?
I thought it was that the university had an incredible opportunity in the 70s to engage the whole of the state in a very different way and on a lot of different issues that we were. So the College of Mines and Environmental Work was developed during that time.
Okay.
There were student internships all over the place. We were sending students were very idealistic in the 70s. They wanted to reform the university. So, well, fine, but you really need to leave the campus and get out the state and learn to deal with some real problems there. So we tried to develop student internships in which students would go into communities and actually work on solving problems. One that I remember very clearly, we had and still have in the state very high levels of teenage pregnancies. You know what all the problems are that follow from that. So Wanda Minor, who was an undergraduate, well, she wasn't even Wanda Minor then. She and her husband Ray were students, and Wanda went out back into, she's from the Livingston area, back into the Black Belt, working on doing something about teenage pregnancy. So students were going out. Jack Shelton, who was a Methodist minister, started health fairs in rural communities. We got great cooperation from the business school, from the law school, social work, all of those.
There were still some challenges in getting everything together, even with the support.
Yeah, there were. The principal challenge, other than the controversy around these new fields, was that the medical school was trying to become a regional center. That meant getting federal funds. That meant getting state matching funds. And they were understandably concerned when they saw big bucks going to Mobile for a 4-year school. We were quite clear we had absolutely no interest in a 4-year school. We had an interest in as I just explained, community health sciences. And they were supportive for a long while until they began to get worried about the state dollars going to these other programs and that curtailing. So I think it was the very day we were to announce the creation of the College of Community Health Sciences, and we had faculty from the medical school here prepared to give their support. They withdrew it.
Okay.
And that began a long and protracted period of trying to accommodate both and adjust both to both. And I guess the crowning blow was that the Accrediting Association came in and looked at this faculty, Harvard, Yale, UAB, medical school, and pronounced them unfit and threatened to withdraw accreditation unless absolute control was given to the medical school for the program here and in Huntsville, but said nothing about the program in Mobile, which was actually the larger program. It's gone on to become a very fine medical school. And that discouraged people like Bill Willard. You know, as I look back on it, and when I went to HEW, I realized from what I saw there that there wasn't a program in the country that was more on target than CCHS, because we were dealing with the same problems that we've got now. That is, we still have people who, even though they may have insurance, can't find a doctor. We haven't really developed and perfected the practices of rural medicine. We're just beginning to realize that doctors have to be supported by physicians and assistants and others. We certainly haven't done much about the business model, because our rural hospitals are failing at an alarming rate. We certainly haven't solved the problem of litigation and the relationship to the law. So the vision is still relevant. And I'm pleased by the progress I see. Your pipeline program for rural scholars is a genius. It's like all things that are of genius, it's simple. If you want people to go into rural communities, recruit them from rural communities. That's a great idea. I mean, you hit your head and you think, why didn't we think about that earlier? And I haven't looked at the statistics lately, but I think a high percentage of the people that come through CCHS go into rural communities, and if you look at rural communities and ask where they came from, a large number of them came from this program. So it's still relevant. The job isn't done.
Yeah, still working toward that.
Yeah, I'm not familiar enough with all that you do, but from a national perspective, behavioral medicine is a reality. The CDC now can talk about social indicators of health. There are people who recognize that the community is a force in the health of people, and that by doing things in the community, you can improve people's health. We certainly have expanded the number of health professionals. So family practice is not just family doctors now. It's a whole array of, we've done that. But we've got problems. We've expanded the number of people with insurance, which we should. I mean, you shouldn't go without health insurance in this country. But simply because more people have insurance doesn't mean that more people are going to have access to the quality of care. And we're having real crises. I mean, the Veterans Administration, for example, has been in the news recently. So while many of the things that we talked about in the 70s here are now commonplace and accepted, the problems that precipitated the founding of the College of Community Health Sciences haven't gone away.
You talk a lot about the intersection, I guess, of community and health.
Exactly.
So,
exactly.
And does that resonate more today with the health profession?
Well, it does in one sense, but here's the difficulty. We still don't know a lot about how communities work.
Okay.
And we don't know enough to know how to fine-tune the integration
Mm-hmm.
of health and community.
Okay.
So that's out before us. Community is a kind of throwaway word. It just means a place.
Mm-hmm.
But a community is not a place. It's a dynamic of people interacting with one another.
Right.
And the
right.
way they interact, the way they relate to one another has everything to do with health. As I said
Mm-hmm.
in this story about the community in Pennsylvania,
Mm-hmm.
human compassion is an incredible health resource,
Mm-hmm.
but we don't know how to generate it, and we don't know how to tap into it, and we don't know what to do when it's missing.
Mm-hmm.
So work ahead.
Mm-hmm. Okay. With what you do know, how would you assess where we are today?
Well, what I know about is very
Mhm.
good.
Okay.
I stay in touch with a great many of the people who were involved here. We've just talked about Dr. Douglas
Scotchfield.
Scutch. He's at the University of Kentucky, which is close to us. In fact, he's done some work with the Kettering Foundation where I am
okay.
now.
Okay.
And I taught a class for him last year. So he's very enthusiastic about what is happening in the college. I've written in several places about the pipeline program because I say I think there's a genius in it because it's so simple and so obvious and works so well.
Mm-hmm.
You're getting national recognition for that.
Mm-hmm.
That's good.
Right.
That's good.
Mm-hmm.
Bill Willard would be pleased. The founders would be pleased.
Mm-hmm. Mm-hmm. Can you talk a little bit more about the other key folks that you work with in creating this vision and ultimately CCHS?
Well, it came from an interesting coalition of people. A lot of them from family practices in towns like Fayette. Dick Rutland, for
Right.
example, was a big force. He had been the president of the Academy of Family Physicians. He was really the pioneer who developed the clinical programs.
Mm-hmm.
He knew how to do that. John Burnham here in Tuscaloosa was the principal person. He took a position with the university, an adjunct position. He continued his practice. He was really great.
Mm-hmm.
And we had wonderful community support. I mentioned Victor Poole down in Moundville and his contribution
Mm-hmm.
of a fish pond. Good support from county officials, legislators, and then this Bill DeShazo, Riley Lumpkin, that whole crowd of family practitioners who came here to train family practitioners. That was great.
Yes. What kind of drove you and the others and kind of kept you working at this, even with the opposition?
Well, it was just so necessary.
Mm-hmm.
It was so necessary, and nobody was doing it quite the way we could do it. There were healthcare programs. Bill had worked on family practice, really going back to his days at Yale. Scotchfield was working on community medicine at Kentucky.
Mm-hmm.
But the notion of an entire university or a model of healthcare,
Right.
that was an energizing vision.
Mm-hmm.
And the response of the people in the state. They needed it. They were willing to support it with tax dollars.
Mm-hmm.
They were eager to work with you with clinics all around the state, Selma, other places.
Mm-hmm.
Kettering was started by inventors.
Okay. Mm-hmm.
Charles Kettering.
Mm-hmm.
If you get in your car and crank it, that's Charles Kettering.
Mm-hmm.
If the paint on your car is not black but some other color, that's Charles Kettering.
Mm-hmm.
Okay. The foundation is located in an area in 50 miles of where we are. Everything from the airplane to the top, what do you call the can where you pull the top off and it flips up, and
Mm-hmm.
I'm sure you don't drink, whatever that is now.
Okay.
The step ladder,
Uh-huh.
all in it. So I'm the oldest living member of the Kettering board, and when I went, they were all inventors. I mean, they were known not by their degrees but by their patent numbers,
Okay.
and they were just energetic and exciting.
Mm-hmm.
Innovation does that. The
Right.
chance to do something useful, the chance to do something that nobody has quite done, the thought that maybe you could do it differently and in a useful way. Those are
Powerful
powerful motives.
And what were some of the high points that kept you all going? Some of the key milestones or the key successes over the years?
The faces
were
of the
involved.
people in the communities
Mm-hmm.
that opened a new clinic, or the people who were getting to see qualified health professionals for the first time.
Mm-hmm.
That's what kept us going.
Okay.
There were no awards, banners, parades, or anything in those days.
CCHS still is relatively autonomous from the School of Medicine.
We were quite clear with the legislature,
Mm-hmm.
and they were quite clear that this was a program of the University of Alabama,
Mm-hmm.
and that it related in part to medicine, and certainly as cooperatively as we could with the medical school. But as I said, it was distinctive in that it was one of the few and one of the first to envision an entire university program cooperating,
Right.
and it was at the center of that.
And
So
is that more commonplace today?
no, it's still not. It is
Okay.
still not.
Okay.
The universities are silos, and have been for a long time. And cooperation across streets is difficult to do, more difficult. So it's a vision yet to be realized, but it's part of the legacy and the heritage of this place, and that's unique. I didn't say enough about the Capstone College of Nursing.
Okay.
There was, when I was an undergraduate, there was a nursing school here, but it left, I guess went to Birmingham. It wasn't here. One of the things that we knew we had to do to have a comprehensive university-wide initiative is that we had to have a College of Nursing. And the College of Nursing filled a critical and indispensable niche in the overall strategy for CCHS.
Okay. Okay. And did that happen? Did that occur around in the 70s?
About the same
as well?
time, yeah,
About
in the
same time?
70s. That was another of the new programs in the 70s.
Okay. Okay. So back then there was a lot of focus or emphasis on, I guess, what we call interprofessionalism today.
Yeah,
The
just beginning.
different-
Yeah, just beginning
Okay.
and the idea was that when you got out into a community, you wanted the business people and the lawyers and the educators and the social work people to work together. What better place for them to learn to work together than here where they got their education?
Right.
If you could start it here, you had some reason to hope that it would continue in the communities. If you didn't start it here, then you had to begin it afresh in community with all the distractions and barriers that were there.
The specialty of family medicine, do you feel like it's gained more respect over the years and people realize the value and importance of it? And has CCHS contributed to that?
I hope they do.
Mm-hmm.
But one of the real deficits in our national system is that we have far fewer people working at the primary level than other countries.
Mm-hmm. Mm-hmm.
We cannot add all of these new people, which we should add, without doing something about that.
Mm-hmm.
I think that is absolutely crucial because with more and more people getting access to health care,
Mm-hmm.
we've got to have people trained. Now, you know, being realistic, in academe there are pecking orders.
Mm-hmm.
And the pecking orders have a lot to do with federal grant money. Will family practice ever have the allure of neurosurgery, the drama? Maybe, maybe not. But there have been times. Remember, there were, well, you won't remember, but there were Dr. Kildare, and there were, you know, the family physician.
Right.
That's right.
Mm-hmm.
So I'm hopeful. Certainly, they deserve it.
Mm-hmm.
Certainly, they deserve it.
Mm-hmm. Any reflections that we didn't touch on, things that you think are important?
Well,
in terms of its history.
Yeah. Its history, its DNA, if you will,
Mm-hmm.
I think positions the college
Mm-hmm.
To be a major force today, because the problems today are unfortunately very similar to the problems that we had in the 1970s. In some ways they're more intense because we've got more people coming into the system. They're more intense because our rural communities are really taking a beating. So I remain as hopeful about the college as I was 40 years ago.
Mm-hmm.
And I think that the potential of a university-wide initiative is still there.
Mm-hmm.
Is still there.
Mm-hmm.
So I am very proud of what I learn about what you're doing here. I think it's exactly on the right track.
Mm-hmm.
And as an Alabamian, I'm pleased that my state has the benefit of what you're doing.
Mm-hmm.
Yeah, if I were talking to the incoming class of third year students
Mm-hmm.
coming here to the College of Community Health Sciences, I'd start by pointing out what they already know. They're entering a field that is changing more dramatically, one might even say radically now, than ever. I mean, it's as dramatic a change as occurred when medicine became a profession, when the Flexner Commission was arguing for a different kind of practice. Health is a right as far as a lot of people are concerned. Never felt like you needed to call it a right, but it is. People are dependent on it. They want it. They want good health. They want good health care. But our system is not a system. I mean, undergraduates coming in to your program have already figured that out. It's about 3 or 4 different systems that are not really well coordinated. We've got a hospital system, and we've got an insurance system, and we've got a federal regulatory system, and we've got a system of medicine, and those, and pharmaceutical drug industry, and those are not run out of one central body, and I'm not sure that they should. In fact, I'm rather sure that they shouldn't. But it adds to the task that young physicians are going to encounter. What they can find here in this program that they can find in few, if any, other programs in the United States is an opportunity to look at the community as a health resource and an opportunity to rub shoulders with other professions that are going to be crucial to their success. The challenges are going to be great. The changes are going to be enormous and unpredictable. But the advantage is that this program uniquely prepares people to work not alone in isolation, but with others and with the communities in which they serve. And I hope and I'm sure that the folks here are as serious about understanding communities and the health resources in communities that can, even though largely unrecognized now, can be marshaled and used to improve the health of the people that are going to be served by the class coming in and other classes.
Mm-hmm. How does an institution like the College of Community Health Sciences, what are your thoughts about how they can keep students engaged in wanting to work in communities?
Well, by the time you're in your third year and you've been impressed by all of the wonderful things that are happening in medicine, you're beginning to think about graduating, and you're beginning to think about going out into practice. And you begin to think about having not just a profession, but a life, and a useful life, and a meaningful life. Okay? And a place like this, college with this kind of focus, is preparation not only for a career, but for a life that's meaningful and useful. And that life is only going to be had in connection with other people. And so this is the other people part of medical education. This place is delivered on what it promised to do, despite some very formidable opposition. And that makes it all the more remarkable.